Okay, we're up to 20 people, so I'm going to start the meeting. It's 2 minutes after, and we want to try to get through the meeting and possibly give you all some time back. I doubt it, but we're going to try. Good morning. I'm Dr. Ernest Carter. I am the chairman of the CCCT, the Community Care Coordination Team for Prince George's County. And this is our meeting that we have, monthly meeting that we have to strengthen and honestly start how we're going to govern care coordination in our county and strengthen our care outcomes for, in particular, for people who are underserved. That's where our passion is. That's what our CCCT will do. So I'd like to welcome everybody. I don't know if there's any new people who joined us, who joined the CCT for the first time, but if so, could you please introduce yourself? I'm not the greatest person in the world for having, little activities before, so I'm just going to ask you just to tell me who you are and where, and in particular, what organization do you represent? So if there's anybody new to the CCCT, please just speak up and let us know who you are.
I'm Carol Pyle. I'm a community health worker at MedStar Southern Maryland Hospital.
Hi, Carol.
Hi.
Hi, my name is Jessica Rivera, and I'm one of the care coordinators at La Clínica del Pueblo.
Hi, Jessica.
Good morning, I'm Emily Pasco, one of the mental health coordinators for Prince George's County Public Schools.
Hi, Emily. Anybody else?
Good morning, my name is Balkisha Kisa. I'm also a community health worker at MedStar Southern Maryland Hospital Center.
Good morning. Anybody else? Okay, well, thank you all for coming. I really appreciate it. We're going to dive right into it and get going. This is, of course, a strategic planning meeting. Really, it's how we're going to establish our goals and then set out to take action once we set those goals. And I know in our last meeting we had brainstorming. We're going to continue that this time, and we're going to be sure that we come up with some use cases that we can think about how we're going to ultimately set action into motion to move the needle here in Prince George's County. So if you don't mind, Kim, can you go to the next slide, please? I'm just going to review, our mission. We're putting it up here, and our vision. So our vision, I'm just going to read it. Our vision in Prince George's County to make Prince George's County a place where everyone has access to high quality and effective healthcare services that are well managed, seamless, and tailored to their specific needs. That's our vision. And we've got a lot of steps and a lot of partnerships to do with that, but we want to be strategic and well organized to be able to do that. So our mission then is empowering healthier lives through efficient care coordination with a strategic systems approach. And one of the reasons we want to be sure to just to emphasize why we're saying a strategic systems approach is because when you have a complex problem like moving the healthcare needle in a community that has complex social determinants as well as clinical services needs, with those types of problems, you have to take a systems approach. And so actually, that's what we're going to do. We're starting some of the initial steps of number one, defining the goals and objectives, and we're going to construct those goals from with an eye on health improvement. And these are community goals. So, and you all are the best people to do that. And that's where we are right now. And then we're going to make all of our objectives that we define from our goals measurable. They're going to be smart. They're going to be specific, and they're going to be measurable, and they're going to be we're going to be able to do them, and we're going to be able to evaluate how well we do. So that's our goals are very important. This is a very important stage of the CCCT since we've started back and started afresh. So that's where we are today, and this is what we're going to do. Ultimately, we're going to identify those potential strategies and figure out which are some of the evidence-based approaches that we can apply, as well as some of our own innovative and creative approaches. And we're going to prioritize our strategies, figure out which ones will have the highest impact, and what kind of resources we have in the community to affect those strategies. And then we're going to develop an action plan, and we're going to make sure we put it into action in Prince George's County. So is everybody happy with that? You got to be on board with this, because this is not easy. We're in difficult waters here, but we know how to swim. So what we have to be able to do is make sure we get from one shore to the next easily. So with that, I'm going to hand it over to Kim, who's going to talk more about our goals, objectives, and strategies.
Hi, everyone. For those who don't know me, I'm Kim Stinchcomb. I'm the manager of the Healthcare Action Coalition. I know all of you are very familiar with strategic planning. Just want to give a very quick reminder of some of the differences between the goals and objectives and strategies. So our goals that we're working on first will be, what is our desired result? It doesn't have to be extremely specific. We'll get more into those specific and attainable of the SMARTY goals when we start listing out our objectives. But what is it that we want to do long term, and where is our overall direction? So then when we look at our objectives, that's when we will start thinking around our time frame that we want to achieve our goals. How will we measure the change that we're trying to make, and what is a realistic expectation for those goals? And then next, our strategies are what is our plan that we're going to use to meet those goals and objectives? So what's our plan of action? What are we focusing on? And then within each of our strategies, we'll have our tactics or action items. So those very specific short-term actions that show how we will reach those goals in our desired timeline. So any questions before we step into the next? I'm going to start by just giving us an example from our Healthy Eating Active Living work group. One of their goals is to improve the health and wellness of individuals with chronic conditions by providing access to nutritious food. Their objective one of their objectives under that goal is, by December 2025, increase produce consumption in people with chronic conditions such as diabetes, heart disease, and metabolic syndrome. And then under that objective, they have 3 different strategies. So they are hoping to, by July 2024, design a Food as Medicine Part 2 program utilizing the recommendations from the Prince George's Fresh pilot program. Then by December 2024, they will collaboratively implement a Food as Medicine program to at least 100 residents with a focus on accessibility, engagement, and health improvement. And then last, their strategy is to, by December 2025, complete an evaluation report highlighting participants' changes in health outcomes and health behaviors. So I hope that serves as a good example of what we're aiming for within the CCCT. And I will pass it over to Liz for our next steps for today.
Hi, everyone. I'm Liz Buchanan at HCDI. So we're just going to review where we are in creating our goals. So last month's progress. So in the beginning of November, we brainstormed our areas of focus. In December, the leadership team for the CDC or CCCT categorized all of your ideas into 3 core areas. So today, what we're going to focus on is creating 2 higher level goals that we want to focus on this year. So hopefully, if we are on the same page and efficient and effective, we could develop objectives for 2 to 3 objectives per goal. If not, this is something that we can obviously continue to work on. And we want to be able to relate the goals to real world use cases to clarify how and why this is a benefit for the CCT members and the community. So next month, as I mentioned, if we don't finish the objectives, we will do that and start developing the strategies for our work. All right, so as you may have remembered from when we met in November, we used Jamboard to create ideas for brainstorming what the CCCT should focus on. So Kim, if you want to pull that up, it's a little hard to read. All right, so as I mentioned before, the leadership team took all the brainstorming ideas and we kind of found that there was 3 common themes amongst everyone's idea: community resource inventory, inclusivity, and data sharing / case conferencing. So for the community resource inventory, this has been a topic of discussion, just wanting to have a list of behavioral resources, housing, centralized community data warehouse. Also, another idea was the community resource concierge. One of the ideas that we had briefly mentioned was if 211 could be an option, and a representative from 211 will be joining us in the February meeting. And so what the ideas regarding inclusivity were having services that were accessible in people's preferred languages, targeting specific subpopulations such as the Ryan White individuals, LGBTQ friendly, and also increasing access to care for individuals that have specific diagnoses. And then the last category that we reviewed, kind of found common themes was data sharing. So would this be possible through sharing information to decrease hospital visits, combining databases, since I know there were several organizations that were new today and we all have our own way of tracking and sharing. And I know that I'm going to shout you out right now. I know Margaret Fowler has had this idea for a while and would really love if there was a centralized SDOH platform. So instead of individuals having to complete SDOHs at various institutions, there was more of a centralized database. And so if there was, that would increase tech sharing of information. So it was the ultimate goal of increasing access to the resources. So those were the 3 kind of themes that we found from all of your input. So I just want to take a moment to turn it over to you all to see how your reactions to how we categorize them and if we feel that we were able to summarize all the thoughts that you guys had shared.
Liz,
And
I
we
just
don't want to have to
say-
call on people. So
Hi,
don't be
Dr.
shy.
Carter. This is Margaret Fowler and Liz and team. I think you guys did a great job categorizing these. And, I think as sometimes it's all really a gray overlap, but, the way you guys have basically categorize them, it gives us now the chance to really see how do they interact across all of these little silos here. So, thank you for doing that. That looks really, really nice.
Thank you, Margaret. Anyone else have any initial reactions or something that we might have missed? All right, well, I'm glad everyone. I'm going to take silence as agreement so we can transition on. And also thank you, Margaret, for letting me shout you out because I know you had shared that in another meeting that we were a part of. All right, And so the proposed goals that we kind of want to look at overall. And so this is, again, we want all of your guys' feedback because this is, what the leadership team thought of. And so we really need to hear from you all what would be beneficial for the community from your perspectives. So reducing barriers to care. So define and improve connectivity with existing community resources, increase inclusivity of healthcare resources, and promote data sharing between stakeholders. So those were the goals overarching goals at a high level that we thought of. So I'm going to turn it over to see if there's any other thoughts or comments, and just check in with Dr. Carter and Kim to make sure I didn't miss anything.
No, you didn't miss anything. So what I want the group to start thinking about is this. So we have these sort of these were the goals or the areas that we wanted to see to measure when we do something. Will we have, the question was, will we be able to have an existing community resource that we can utilize to help in our work, improve our work? Can we increase the inclusivity in our work with our health street? And can we have a promotion in how we share data among stakeholders? So this is what we're going to measure. We're not going to measure everything, but we're going to measure this. So we have to ask ourselves the next step. Well, let's define a use case. The next thing we have to do is think about, okay, I know we have community health workers here. We have people who manage care coordinators, care coordination projects, etc. And then there are people who are resources. We need to define at least 1, 2, or 3 use cases that utilize these 3 goals so that we can then sort of flush it out. Do you understand what I'm saying? And I know I just saw in the chat about the Z codes and we left that part out. It was one of the other areas we are going to include. So so I apologize. We will make sure we include that in the reduction of barriers. So we've got to think about a use case. Now I want to be sure some of the elements that should be in that use case, how we define it is, one, we have to define what is going to be the target population we're going to look at starting out. Are we going to look at extremely high risk patients? Are we going to look at moderate risk patients? And we could even define it to a subpopulation within where you all work. You can say, okay, our use case is going to be people who have who are in a specific area, a specific zip code, a collection of zip codes that have certain disorders that we want to show a change in. So they could have, let's say, hypertension. We were concentrating on people with hypertension in a zip code that we know had a slew of social determinants. And what we want to do is to move the needle on hypertension by coordinating their care. And we know that the slew of social determinants could be food insecurity, housing, et cetera, but they also will have behavioral health problems, et cetera, and they will have environmental problems, blah, blah, blah. Those are all the variables we know we have to address. And we need to understand how, once we define the use case, like if we define it as somebody with food insecurity, for instance, then what would our community health, how do we utilize our community health resource database that we're generating, and where are the gaps in that, and how are we going to make that inclusive? How are we going to increase the inclusivity of those health resources, and what kind of data sharing are we going to use to be able to help that population? So that's sort of right off the top of my head. That's what a use case will be. I want you all, and you all these use cases should come from you all, stuff you're doing right now. You say, I'm serving a population of X. We're trying to get some chronic disease or some health outcome changed in this area. We're trying to decrease the utilization of emergency room, et cetera. That's what we really want to do. And we've got a care coordinating unit that's doing X, Y, and Z. And we're measuring it in this way. And we want to be able to take that use case and understand how, and ultimately, just like what HEAL did, how are we going to address that? So, Kim, if you could go back to the HEAL, the example that you showed.
Sure. And then I want to make sure Kelly has some comments in the chat. And it would be nice if we could get a little bit of clarification, Kelly, at least on my end, for capturing the screenings for social drivers of health, and if you have any additional thoughts there.
Good morning. The social drivers of health that I put in here is a kind of a compendium where you can open it, click on housing, and it will take you to some resources, or transportation. It will take you to resources. It includes the 5 drivers that CMS is hoping that hospitals will track in the 2024 timeframe. So I don't know if that clarifies, huh?
No, that's good. Thank you, Kelly.
Sure. And then I just wondered where Chris was with tracking the Z codes and the social determinants of health. I know Dr. Carter and I met with them. Oh gosh, it's been years ago about that process. And I know some of the hospitals are putting the Z codes, the 55 to 65, especially those 5 drivers, into their EMRs and tracking that way. So Chris would have access to that. So I don't know what access you have to Chris as far as looking at aggregate data.
Chris is making a lot of strides in that area, they are starting to pick it up. They translate their services from being primarily hospital focused to being more outpatient and public health focused. And so they do things in sort of a stepwise way. Sometimes a little bit too slow for me, but they do it, and they are in this space. And I am continuing to work with Chris because I believe that they have they've established roots, and they have and they're part of the infrastructure, and we have to be able to leverage it. So from our use case, we will use Chris in our use case. But one thing we'll have to do, though, is we'll have to think about if Chris can't service all of our data sharing needs, we have to think of what gap technology would we have to use, or to be able to do that can serve as a conduit between what we're trying to get accomplished and what Chris can do. That's going to be critical in forming how we form our infrastructure in Prince George's County and address those. So, but to your point, Kelly, we definitely will work with Chris and going to work with Chris.
Well, I know they've increased their physician participation and hoping to get them to increase their Z code documentations for the 55 to 65, which are those social determinants. So hopefully we'll see that improve here. But I also wanted to know how effective your Unitas partnership has been. We met with them again several years ago, and I know that we have really, through the iPro QIO, have really stepped up participation with them in the New England states and New York. So Prince George's County had a really pretty effective partnership with Unitas. Is that still, and it was basically for community-based organizations to be able to refer back and forth and see where patients were going and what services they were utilizing.
Yeah, Unitas is, when we look at how we're going to approach this, Unitas is squarely in our, how do you say, in our toolbox. We're going to use them, and because we looked at, and Juanisha is on the line. We looked at multiple these gap. I'm calling them gap services between Chris and what you need to do, and so so Unite Us is one of those entities that we definitely will think about using. That's why we're just sort of starting with a blank slate here. And what we want to try to do in the CCCT is, because we have people from MedStar all the way to, Prince George's County community health workers, we have people all over that are using multiple different systems. What we're going to do is we're going to, especially when we're talking about connectivity with community resources and data sharing among stakeholders, we're going to start to inventory what that is. That's where we're going to start. So, and then once we understand the gap, then we're going to maximize which one of these entities will be best for us, or whether it's Unite Us or whoever, or where should we use them, and in what part of Prince George's, or et cetera. We're starting from a blank slate. So that's why we need to start with a use case, and we need to be able to we need to flush out the details. The details of how we're going to meet these to overcome, reduce the barriers that we've identified as priority barriers. So, and we won't be able to reduce every barrier because this is a complex problem. I know our community health workers on the line can tell you right now that this is a very complex problem. And we don't have all the resources in the world in Prince George's County. But what we're going to do is build a system that will optimize how we get the work done. And then we will be good public health stewards and advocate for policy change so that we can get more dollars in to build up our resources in Prince George's County. So we're going to do all of the good public health work. But we're going to start here because I believe what you all have identified in terms of reducing barriers to care are some of the critical things we do need to look at and evaluate. So, having said
Dr.
that,
Carter, just an FYI, I put the Unite Us link for DC and Maryland in the chat for those who may be not familiar with Unite Us. I know there are some new folks in this group, so you can take a look at that. But
absolutely.
So anyway, it was being utilized. So hopefully you guys will get back to that. Thanks for letting me interrupt.
No, Kelly, look, we've been doing this a long time now. So this is part of it. One of the things we want to be sure of in our use case is that we have at least a reasonable representation of the stakeholders that are usually involved in care coordination, which means it would, in terms of defining our use case, it would be good if we used, a care coordinating body, but also case managers from the hospital system, at least a private practice, the health department, just the stakeholder and the resources, like whether it's Unite Us or whether we're food pantry resources, whatever. I want to be sure that we get all the major categories of stakeholders in our use case so that we can have a robust discussion about how we overcome these barriers. One of the things the reason you want to make sure you cover the major categories of your stakeholders in your use case is because we don't want to go down the road and leave a big segment out when we first start to build, our underlying infrastructure. So anyway, having said that, Kim, if you could go back to the Hill example.
There we go.
So, and one of the things that Kim has been very good about in the health action, in our health action committee, it's not a committee, I'm sorry, LHIC, I'm just going to say, is that what they've done is that they've set goals for getting these goals and objectives. But if you look down in their strategies, they have concrete strategies that they have implemented based on what they decided was a way to address some of the categories that they wanted to try to address. And in particular, I like the way they with their prescription health as medicine approach. because what that does is it brings in a lot of the categories that you need to figure out how to overcome a barrier for helping people get food. So that's a good example. But so, and that's one, I mean, that's could be a use. We literally could take one of these and make it into a use case for care coordination. So anyway, I'm going to hand it back over to Kim. So, because I just wanted to be sure I talked a little bit about that, about us defining those use cases, because that's where we're going to have a lot of robust discussion. And in particular, I want to really find out from the community health workers, you know, how they see these barriers and how and what kind of tools they're going to need to try to overcome those barriers. But anyway, Kim, I'm going to hand it back over to you.
Sure. And I'm just about to flip us over to open up our Jamboard for use cases. But I appreciated Kelly bringing up the social determinants of health codes. So Tornisha and I were actually on a call with one of our partners from Suburban yesterday, and they also mentioned those social determinants of health screenings that are going to be mandated at hospitals. However, what they weren't sure about, and I'm not sure if we have any other hospital partners or partners who are on that can speak to this a little bit more, but was how those screenings would then be addressed. So what would the next steps be after they identify someone that says that they have a social determinant of health need? So I think that could be something for this group to keep in mind as well, but I'll open it up if anybody has any additional knowledge around the next steps for those screenings.
Kim, this is Margaret, and I apologize for being offline, but I'm just not feeling very well. But I did want to say that, you know, what's the beauty here is that, you know, TLC can work with the hospitals to get that information and also really be able to coordinate it. That's a beautiful thing about Prince George's County, is that we have these wonderful opportunities to communicate and have direction where we can collaborate across, you know, health systems. And TLC has been really working hard to do that with the behavioral health side. And, you know, we're also working from the chronic disease side. So, you know, we can certainly look into that with our connections at the hospital. And I just wanted to say, Dr. Carter, you are singing my song. I feel that, you know, this is something that has been heavy on my heart too, in the many years that I've been within the healthcare system. You know, I think one of the things that I would like to maybe put out there would be, you know, and we started this with the Adventist Fort Washington Medical Center, but creating a culture of wellness within a geographic neighborhood. Just to give an example, you know, with we identified Giant Food in the food pantries. We had a doctor's office. We have the hospital. So, you know, we have started that, and I could certainly, you know, we can figure out if that is something we want to pursue. But, you know, we do have a lot of the components, and with developing that culture of wellness within that geographic neighborhood of Fort Washington with all those players. Because in that way, and figuring out like how do we maybe start there, figure out where there may be other opportunities to add to that care team within the Fort Washington area.
Yeah, that's great. Thank you. That's great.
So
I will tell you all.
Go ahead,
Go
Dr.
ahead.
Carter.
Yeah.
I
Well,
was just going to say, give a quick reminder for how to use the Jamboard. So you can just go ahead and add, once you open the link that I put in the chat, you can add a sticky note here and add any use cases that you have, and then save them under the corresponding goal area.
So
go ahead, Dr.
one thing
Carter.
one thing I was going to say is that there are some elements of a use case that we really do need to make sure it's included. One is that part of our use case should be to to look specifically at high utilizers and I would say for each hospital system that we have, those hospitals have high utilizers, and getting to those populations to help them. That's sort of like a cry for help. The high utilizer, people who overuse the 911 system, the people who overutilize the hospital emergency room, is a cry for help in a community. So we should start. I'm just saying that we should start with looking specifically at those subpopulations. It tends to be about 3% of a population that are the really super high utilizers. And we should look at that starting there, because we know that there's a great need, because it's like a cry for help. So that's one thing I think should be part of our use case, is that when we start to define populations. The other thing is that we should at least have a population that does not have a language barrier, and a population that has a language barrier, because even in the overutilization case, we want to be sure that we address, and when I say a language barrier, a cultural barrier, some barrier that's cultural in nature, and language tends to be a big one. So we need to be sure that our use case includes that, so that we can address how our system would address that in particular. So those two things are very important. That one, we look at high utilizers, and number two, we look at subpopulations that don't need a lot of that don't have like a language barrier, a big cultural barrier, and one that does. Because when we do a use case, we want to be sure we have sort of like something to compare to. So we're going, I want to be sure that even with the high utilizers, we're going to have people who are high utilizers, and we're going to have people who are not high utilizers. We're going to have people who are cultural barriers and people who don't have cultural barriers. And that will help us with understanding what community resource inventory we need, how to increase inclusivity, and it'll help us to understand what we need to do with our data sharing. And in the midst of all that, it also will help us, Kelly, with helping systems utilize Z codes. And I'm working with a hospital system now that's struggling with how to get Z codes into their, to utilize the Z codes in their electronic medical record. So I know it's there's a lot of barriers there, but that's when, when I look at a use case now when we say we don't want, so I'll just leave it at that. I'm talking too much. Kim, you're supposed to be my, you know what? You're supposed to rein me in.
I think I heard, who was that was speaking out? Was that Kelly or Margaret?
It was Kelly. I was just going to say that I put a note in here that the hospitals that are recruited in Prince George's County that work with the QIO for this statement of work receive quarterly readmissions on the Medicare fee-for-service beneficiaries, and it specifically tells them the number of, and we refer to them as MVPs versus high utilizers. MVP means multi-visit patients. It just sounds classier. So I know Maryland Department of Health has started using the MVP language as well, but it shows them per rolling quarter the number of multi-visit patients that they have. So if they can narrow down, we cannot tell them who those patients are. CMS does not allow that. But they could actually drill down and say one of the hospitals has maybe 40 multi-visit patients during that rolling quarter. They should be able to drill down and figure out who those patients are and use them as one of your use cases.
Yeah, absolutely. Absolutely. The other thing about our use case, we should just keep in mind, I'm just throwing things out to keep in mind when you develop your use case, is that it should align with the people, the CCC team members. It should, some aspect of it should align with what you're currently doing. so that, because it will, and I'm sure all of this overlaps because we're sort of taking care of the same subpopulation, but it definitely you should be able to see aspects of what you're doing in our use case. Anyway, I'll leave it at that.
So as we're going through, maybe it would be useful to think of them one at a time. I know a lot of people put a need for a community resource inventory. So how would a community resource inventory benefit your work, or how could you see that being used in our county to improve access to care?
So Kim, this is Margaret. I think the other thing, since Prince George's County is so large, and when we talk about community resources, I think when you go into these geographic areas, some have a lot and some do not. So I think, again, that is something that, again, would help us identify where are those gaps that Dr. Carter's talking about, and do we need to develop resources there to, have equal access and opportunity. So we can say the community resources, but I think it's real important to know where they are, because transportation is always a major issue and getting people to get those resources, So I think creating, again, that culture of wellness in a neighborhood where we bring those resources to support prevention, wellness, self-management is going to be vital too.
So for the community resource inventory, we need a baseline. And to Margaret's point, it needs to be geographic in nature. So we should be able to look at Prince George's County and see where the resource gaps are. So we sort of need to know, what we have and where they're located. That's a good point.
Dr. Carter, this might be a fun thing to do. I know there's a lot of geo mapping with food pantries. We can have overlays of, like, if we could come up with what would be a community that supports health and wellness, and, like, having a grocery store, having, a physician, having, within a geographic diameter, like, what would a community of wellness, health and wellness that allows access to care, and I don't know how that's defined. I'm just talking, but I think if we could find a community where the wellness score, or however we want to define that, is doing well, how do we replicate that model in other areas that may not be that way? So again, I don't know what that looks like, but that we know that there's some communities that do not have a food store. We know that that is a major issue, and it might be, where's the closest doctor or FQHC, because we know we need to have access to food, access to care, even wellness screenings, and then, access to other things. And what does that look like to create that culture? So I don't know, that's just thinking a little bit more broad, but, then if we have the idea of what we need to have within a certain mile radius of a person, a transportation system, can they get there? Is it on a bus route? Those kinds of things. I think then it allows us to sort of go in and figure out what we need within each of these areas of Prince George's County, because they're so different.
Yeah, no, that is absolutely true. And so there's long-term goals, because to get to, and people who've been in public health know this, to take an area and transform it into a healthy area is a Herculean task. It requires, policy and legislation and infusion of dollars and dot. But that always has to be our goal. And we do need, as you pointed out, Margaret, we need to have a baseline of what, and to be able to define what does a healthy community look like, compare it to the communities that we are trying to serve, and understand the gap. And then a lot of that is going to be left to policy, because we won't be able to, meet some of that. And I think a lot of our community health workers are running into that right now. They just can't link people to the resources that they need. What we have to do in our short term is to leverage what we're doing, the resources that we have within Prince George's County, and perhaps even leverage some outside of Prince George's County just to meet our need. And if we can't meet our need, then we have to make sure that the folks who advocate for building those in that community, who are advocating for that community, have a louder voice so that they can get the funding and the infrastructure they need to do that. And so that's why we're here, because it's the problem, and the community health workers can tell me more about this, but from my experience working with them for the last 12, 13 years, is that we don't have a lot of resources in Prince George's County, and we need, or there's a lot of not knowing perhaps that there are some resources and that we could leverage that they don't know. That's why the community resource inventory is really important, that it's not only done, but also it's thorough, and we have to understand how to best leverage it. Because sometimes even with a community health resource, if you don't know how to make a referral to it and it refers back, then you can be delayed for 6 months for trying to get somebody into X because of all of the barriers. One of the things that the CCCT wants to be able to do is help with those referrals, and be able to be sure we can identify those resources. So no, I hear what you're saying. We got to hear at least something from a community health worker. I need a little bit of input from community health workers so that I can sort of shape up my thinking. And when I look at this GEM board again, and when we start to really formulate what this use case is going to look like. So can I hear at least from one community health worker? I know there's at least two on here because they identified themselves. They're new. And I don't want to have to call names because I got them right here. All right, Emily.
Hello.
Hi.
Sorry.
Who is speaking?
My name is Bilquis. I'm one of the community health workers from MedStar Southern Maryland.
Okay.
And I did want to say it is very difficult to find resources to connect clients to. I know earlier there was a question regarding how hospitals are utilizing the new social determinants of health screenings. The way our hospital is utilizing it with our current pilot is that we receive high-risk clients who score a certain number. There's a certain, based on if they're low risk, moderate risk. If they're high risk, they are sent to a community health worker. We try to connect them with resources based on the needs identified. And I will say it has been very difficult in finding resources to connect them to in Prince George's County. Because, some of the resources that we could have sent out maybe 6 months ago aren't the same resources that we can send out now, because things like funding, for example, rental assistance, that is very difficult to come by. Housing, those kind of resources can be very difficult to find, especially food resources are a little bit easier due to the fact that a lot of faith-based organizations will have like food pantries or ways to connect families with foods. But housing, rental assistance, things of that nature are very difficult. And due to the fact that COVID kind of resources that came out during the pandemic have been cut back extremely, but people are still facing those same issues. We're finding that it is a bit difficult. And one way that we have tried to streamline our process is through creating a similar community. We created a community health worker toolkit amongst our team, and just found resources that we can send out to individuals, which is very similar to the community resource inventory that is being discussed. And I think during my research, I found a Prince George's Community Resource Guide that was published, I believe, in 2019 or 2020. And if anybody is interested in that, I can try to find it and forward it if that can be used as a baseline. But I know that a lot of the resources on there are not updated accordingly, because we try to utilize that to create our own toolkit. So that is just my experience. I'm a relatively new community health worker. So if there is anybody else on the call that would like to, either share their experience, I'd love to hear it as well.
Thanks for sharing. I think that is a really critical use case for a reason for building the community resource inventory. And I think Liz or Dr. Carter mentioned that we are hoping to have, or we're planning to have, a representative from 211, Maryland 211, join us next week. So they do kind of have this home for community resources to enter their resources, and then they can make connections. But what we need to find out is how we can get a little bit more access to that data, and if there's any opportunity for data sharing. So thinking of them joining us next month, make sure that everybody starts thinking about questions that you have, or ways that we can utilize that resource better, or pull information specifically around Prince George's County resources, and how we can work together. So if we can encourage more people to disclose their resources to 211, and then there's a one-stop shop where all of those resources are held, then we can come back and share those with our partners that are connecting people with resources. And I see Anita made a note as well, if it's possible to have a database of community resources, or can each organization share what resources they offer, that will give us a start. I definitely feel like the community resource inventory will be a massive collaborative effort, because as people have seen from trying to build their own inventory, it's impossible to keep it up to date. I know we did it with our COVID call center as new resources were coming up or closing down. And it's really important to have one that everyone refers to frequently, and they can take a little bit of ownership over updating their own resources.
So we're coming close to the hour. This meeting is hard to do within an hour, but we're coming up close to the hour. So I want to be sure that I don't infringe on everybody's time. I will say really quickly about community resources is what Kelly brought up was that Unite Us does that for communities. They actually do that kind of work, and as we define what our needs are, again, we will look at some of these entities that actually keep an updated inventory of community resources. One of the things that is the barrier to them is it costs money, and we'd have to have the money to do it. But that's never stopped us before. So we will explore this in detail. But I think we'll have to. I'll hand it over to you, Kim, to close out, because I don't want to take people over the time. I know they have work to do, and I really appreciate people coming and sharing, because this is very, very important to us. So Kim, I'm going to let you close it out.
Sure thing. Thanks, Dr. Carter. So I think a few takeaways are, if anyone has any thoughts around the proposed goals, please share those or bring them back. If not, we can start thinking around what our objectives will be underneath those goals. And I think the use cases will really feed those objectives. And then from there, we can start determining what our next steps will be in terms of our strategies. So now I'm going to open it up to a few community announcements. I will start us off. We wanted to share that starting January 1st, 2024, Maryland Medicaid is expanding gender affirming healthcare services. So for more information around what services are available, you can visit the website, and I can put that information in the chat, and it'll also be available in the slides when we pass them out. But very relevant changes for access to care for all. And we also wanted to share that the health department is holding a status neutral summit, tailoring our service for Prince George's County on January 31st from 8:30 a.m. to 4 p.m. And this summit will really highlight person-first strategies to diagnose, treat, prevent, and respond to HIV. So we will also leave registration information for everyone, and in our announcements with the notes. Our next meeting will be Thursday, February 22nd from 11 a.m. to 12, and also virtually. Again, we'll have a representative from 211 on. We'll try to see if there's anybody we can talk to from some of these other resources who could pop on as well, or we could start those discussions internally. Did anyone else have any announcements or community announcements or events coming up that they want to share?
This is Jay Summerlet. Just real quickly, I put in the chat that right now we're conducting our homeless count, our annual point in time count across Prince George's County. We've got teams out today and tomorrow that are identifying people who are sleeping in a place not meant for habitation, abandoned buildings, in their vehicles. We've been finding quite a few people in sleeping in their vehicles in local park and rides. And so if any of your organizations encounter somebody who is sleeping rough, they can contact the homeless hotline at 888-731-0999. And I'll also put my number in the chat. Thanks.
Thank you, Jay.
This is Kelly. Just quickly, who would I send things to in this group to get it out to everyone in the group? I put quite a few resources in the chat that I think would be beneficial for you all to review so you're not recreating wheels. And then secondly, we have a quarterly forum that's called Share from the Chair for our links, LINKS, which is Local Interactive Network of Knowledge Sharers for community-based organizations to come and just talk about certain things. We have topics. The one that we have February the 8th is on the importance of medications and adverse drug events and how community pharmacists and community-based organizations can collaborate to reduce those for patients. So who would I send things to?
Kelly, you can send them to me and I can make sure to get them to our communications lead who puts out the bi-weekly newsletter for the coalition. We also have a calendar on our website where you can add events directly, or I try to add them if I see that somebody didn't get a chance to get to the calendar.
I don't know that I have access to that calendar, but if you will put your email here in chat quickly, I will snatch it.
Excellent. And I believe you did send me the quarterly information, so I can push that out to this group and then try to get that into our next newsletter as well.
Excellent. Thank you so much.
Any other announcements as we're at 12? All right. Thank you all so much for a great meeting. Thanks for your collaboration, and we look forward to seeing you in February.
Thank you all.